Hi, this is Dr. Bernstein with our September 2019 teleseminar. Before we start answering questions, I was asked to speak on a special subject. I was asked to talk about my patients who did not have hemoglobin A1Cs under 5 and therefore got diabetic complications. The trouble is that the patients whom I am treating have A1Cs about 5 or under 5. But I see many new patients who are new to me. I did not diagnose their diabetes, but they've had it a number of years, and they'll come in with an A1C of 6, 6.5, 7, and I'll do a physical exam. My physical exam is really 10 pages long. 8 of the pages deal with just complications of diabetes. And on average, for these people, I find 15 to 20 different complications of diabetes. They're rarely blind or unable to walk when they come here because they usually have to travel great distances. They have to be able to read my book because I won't treat anyone who hasn't read my book, Diabetes Solution. But these people who have A1Cs of maybe 6, 6.5, going by the ADA guidelines, perhaps for years and years, always have many complications. Every chart that I have of a patient that I'm treating starts off with a load of diabetic complications. Many of them get better when we have normal blood sugars. So things like double vision, which the patients usually don't even know they have, but can be elucidated if you look through a red lens with one eye and not with the other eye. That afflicts most of the new patients, but after a few years of normal blood sugars, it reverses. And many of the neuropathies reverse, pain in the feet and so on. So we can reverse many complications with normal blood sugars, cannot reverse all of them. If someone is blind, you're not going to make him sightful again. So the game plan really should be to have normal blood sugars. For adults, that means blood sugars around the clock of around 83, and for kids in the 60s and 70s. Before we start with our questions, I want to remind you that the answers I give are generic answers. I cannot know the entire medical history of someone who asks a question. I can't do a physical exam on him. So I guess at an answer based on my knowledge of other people. So my answer for Mr. X may not apply to Mr. Y, and might not even apply to Mr. X, but might apply to the other guy who didn't answer it and didn't ask a question. First question. I'm a 63-year-old male who exercises regularly, lifts weight, and wants to lower his A1C, which is currently at 5.8%. I have cut out added sugars as much as possible and recently cut way down on carbs. Problem is, I don't want to lose any more weight. What diet should I follow to accomplish both goals? Well, first of all, you should read my book because we do talk about both goals. And you may have lowered your carbohydrate, but you may not have lowered it enough. For adults, I usually recommend under 6 grams of slowly digestible carbohydrate for breakfast and 12 for lunch and 12 for dinner as maximums. For children, it would be proportionately lower based on their weight. I usually recommend more protein than people are eating, especially for people who are exercising. So for you to gain weight or not lose weight, you may need to eat more protein. Now, you haven't said whether you're a type 1 diabetic or type 2 or whether you take insulin or not. Frequently, adding protein may require the use of insulin, or if you're already taking insulin, may require higher doses. So all of this combined should meet your guidelines, but it's all in the book, so read the book. This is from a 60-year-old female. Recently, I've had to up my Tresiba by 2 units because of rising blood sugars for no reason, without eating anything for hours. Could this be insulin resistance suddenly showing up? Well, again, if you read my book, Diabetes Solution, it'll point out a number of possibilities. One possibility is infection. And we even have a chapter on the possibilities of infections in the teeth or the mouth. Then another possibility is that you gained some weight and became more insulin resistant if you're a type 2 patient, or even a type 1. By gaining weight, they require more insulin. Then with Tresiba, which comes in pens, there's a big hazard of losing insulin, where you think you're getting a dose that you injected, but it's actually leaked out of you. And for that reason, I tell every person who's using an insulin pen, actually I tell every patient who's injecting insulin, to wipe their hand over their skin at the site of injection, after the injection, to see if it's wet. I've been doing this since I was a child. Now, back when I was a child and was on a high carbohydrate diet, I was injecting in one shot 200 units of insulin. We had U500 then, so it wasn't that big, but it was a pretty big dose, and it almost always leaked. That was without a pen. But and I also used to smell my hand because the insulin had a preservative in it that had a characteristic smell, and I'd wipe my hand, see if it felt wet, and I'd smell it. You should do this sort of thing with any insulin injections, but especially if you're using a pen. And if you're getting leakage, you have to figure out how to avoid it. One way is to use longer needles. When I use an insulin pen, I use a 12.7 millimeter needle for all my shots, not the 3 or 4 millimeter needle that comes with the pen. I have many of my patients actually using an insulin syringe to take insulin out of a pen cartridge. If you're clever, you could figure out how to do this. When you press on the plunger of an insulin syringe, your thumb can be pretty powerful. But when you push the button on a pen, you're not pushing out the insulin. You're releasing a spring that you wound up when you turned the knob on the pen. And that spring is not very strong, and it might not be able to fully eject all of the insulin in your dose deep enough. So it may be necessary for you actually to take an insulin syringe and go to the cartridge that's in the pen and draw your dose out of the cartridge while it's in the pen. There are other cartridges that are removable from pens. Likewise, you could fill them, use them with an insulin syringe. When drawing insulin out of a cartridge, it's not as easy as drawing insulin out of a vial or bottle, because drawing the insulin out doesn't merely remove insulin. It moves the little stopper at the far end of the cartridge, and there's a lot of friction between the stopper and the glass of the cartridge. So you're going to have a lot of resistance to your pulling. And if you pull fast, you're going to create a vacuum and draw air up the far end of the syringe. The back of the syringe is going to leak air because of this vacuum. So you have to pull very slowly on the plunger of the syringe so that you'll not get any air in your syringe. Next question. Type 1 for 16 years. I have been on your low carbohydrate diet for 2 months after discovering your book. I take 8 to 9 units of Lantus in the morning and 7 units at night. I take Fiasp, that's that new very rapid acting insulin. I take Fiasp before meals. He takes small doses before each meal. I vary the dosage of bolus insulin depending upon what I am eating. Well, right off the bat, a major problem. He's not going to be able to get consistent results because he's guessing at the amount of insulin he needs. Many people do this, and people who do this don't get A1Cs under 5 and rarely get them as low as 5. I've been experiencing an increase in blood sugar in the afternoon to around 110 to 120. So he wants to know why this is happening. So now I'll speculate. First of all, he may be only estimating carbohydrate when he calculates his bolus doses. So you have to take protein into account. And in reality, you have to work out what dose works for what meal and keep that meal constant day after day and keep the dose constant. And if you're going to change your meal, you're going to have to change the dose, and that means more experiments. Another possibility of problems is the insulin he uses. If you're on a low carbohydrate, high protein diet, you don't use an ultra fast insulin because the insulin will work faster than the food. So what'll happen is his blood sugar may go down initially after the meal, or it may be just right to initially cover the first part of the meal that was digested, but then it finishes rapidly. So later on, as the rest of the meal gets digested, the blood sugar goes up. So I never have my patients using ultra-rapid insulins like Fiasp or Humalog for meals. Now, there are exceptions. I've found that some type 2 diabetics, especially obese ones, will have slow absorption of rapid-acting insulins, slower than other people. And sometimes we can give them a rapid-acting insulin for meals, but that's usually not the case. Another possibility is gastroparesis. Someone's been type 1 for 16 years and has certainly, if they've not been using my book, have had high blood sugars for all that time. They certainly must have autonomic neuropathy, which includes gastroparesis. That's delayed stomach emptying. So you take a shot of insulin for the meal, whether even if it's a reasonable insulin like regular insulin, your digestion is still slower than the insulin because you have gastroparesis. It might take you many hours to digest that meal. I've seen cases where it takes 12 hours and even longer. So we have several problems. They're all covered in the book Diabetes Solution. Bedtime level at 79. Ate 2 ounces of cheese and 30 minutes later tested at 82. Set alarm to test 4 hours later, was at 73. What is the best way to correct if patient does not have glucose tablets? How do doctors determine when prescribing glucose tablets is necessary? I'm not taking insulin and have type 2 diabetes. Well, first of all, doctors don't have to prescribe glucose tablets. You can buy them at any drugstore in the USA. If you're out of the USA, most drugstores still have glucose tablets, so you don't need a prescription from a physician. I suggest that you read my book. There's also the possibility, certainly for people who take insulin, to use liquid glucose. You may not need any glucose at all if you're a type 2 diabetic and not taking insulin. The only thing that might cause true hypoglycemia would be a sulfonylurea drug. And as my listeners know, I recommend strongly against these drugs for a variety of reasons. That would, getting rid of the sulfonylurea and replacing it with a little bit of insulin can be of great value for a variety of reasons that are covered in my book. Can an A1C drop too quickly, compromising health in any way? Not to my knowledge, except for one situation. My type 1 diabetic daughter went from a 5.1 to a 4.6 in 2 months. Well, congratulations. You must be using my book. There's only one situation that I know of where the A1C, I can think of two situations. One is when you adapt to a certain blood sugar, if you suddenly have much lower blood sugars, you might feel hypoglycemic, even though your blood sugar is not in the hypoglycemic range. You just get used, you're not used to truly normal blood sugars. So for some people, you want to lower the blood sugar slowly. If your daughter is not uncomfortable at an A1C of 4.6, don't discourage her. The other problem is for people who have high serum IGF-1 levels. That's insulin-like growth factor. It was discovered that if people have high IGF-1 levels and already have diabetic retinopathy, proliferative retinopathy, it can get worse if you rapidly normalize blood sugar. So if she had proliferative retinopathy and also a high IGF-1, then you want to lower blood sugar slowly. Can I reverse minor amount of kidney damage if I start to control my blood glucose levels? Well, I did, and mine was not a minor amount. This was way back around 1969 when I was showing 4 plus dipstick protein in my urine every time I peed. I had learned, I'd read somewhere that you could read about kidney damage in a diabetic. You could learn about kidney damage if you test the urine for protein. And they had dipsticks that you could get at the drugstore, and mine would turn the darkest color every time I peed on it. I subsequently found, after I went to medical school, that a 4 plus reading on these dipsticks corresponded to at least 1,500 milligrams of protein in 24 hours. And I believe normal is under something like 130 milligrams. So I was more than 10 times the normal range. So I had very significant kidney damage, and that reversed after a number of years of normal blood sugars. I have no protein in the urine today. Can you recommend a diet for a 15-year-old boy who is growing and is constantly hungry? He doesn't like eggs. Well, first of all, you should read my book, because we have sample diets in the book and meal plans, and there are many high-protein foods that he can eat, but he can also eat low-carbohydrate vegetables that are not rapid-acting, and we list something like 40 of those vegetables in the book. So there's a load of vegetables, and there's meat, fish, seafood, poultry, cheese. So there are plenty of things for a kid to eat. Could unreliable, inconsistent insulin pump readings also be due to gastroparesis? Well, gastroparesis is not responsible for errors in an insulin pump. You could get an unexpected reading if you have gastroparesis and don't know you have gastroparesis. For example, if you theoretically take the exact right amount of insulin for a meal with the right timing, and your blood sugar then goes way down after the meal, but then way up 6 hours later, that would be gastroparesis. Has nothing to do with the accuracy of your pump. Pump problems are universal. I just yesterday spoke to an insurance doctor who had rejected Tresiba insulin for a patient of mine and said, why isn't she on a pump? And I asked this doctor, who was a lady, if she had ever treated a diabetic with a pump. No, because she has never treated diabetics. So she's making the decision for the insurance company on how diabetics are to be treated, and she's never treated a diabetic. This is what's happening today. I am a 27-year-old student, and I just got diagnosed with diabetes type 1. Should I already be taking ACE inhibitors as a precaution for nephropathy, that's kidney disease? The American Diabetes Association suggests that all diabetics take an ACE inhibitor. They also recommend statins and aspirin and a number of other things, because they're expecting all diabetics to get kidney disease. Why? Because they're advising that a hemoglobin A1C of 6.7 is a normal, is normal, where it's in reality up in the vicinity of 160 milligrams per deciliter, which is double normal. So if you're going to read my book and keep your blood sugars normal, keep your A1C under 5, you don't have to worry about taking ACE inhibitors. Since I've switched to a low-carb diet, I've lost a lot of weight. How can I regain this back? As I've said over and over, a good way to gain weight is to increase your protein intake, and also, if you're a type 1 diabetic, slightly increase your insulin. If you're a type 2 diabetic, you may have to start on insulin in order to gain weight. And I've had most of my type 2 diabetics are on small doses of insulin anyway, because aside from sulfonylureas, which have severe problems associated with them, it's very hard for a medication to have a major effect on blood sugar. So the oral medications and even the injectable ones for type 2 diabetics, other than insulin, don't have a big effect on blood sugar, and most type 2s need some insulin anyway. The only patient, type 2, I have who does not take insulin is a patient who owns an airplane, and he will not be allowed to fly over some states if he were taking insulin. And we have a number of tricks and concoctions that he's taking to keep his blood sugars normal without insulin. It is very hard. And fortunately, his diabetes is mild enough that we can get away with it. Should I be taking vitamin supplements as a diabetic? If so, which ones? I know that vitamin B12 is very important. I know that you usually recommend taking vitamin B injections. Boy, I'm sure I don't know this patient, because I don't recommend people at large taking vitamin B injections. There may be other Dr. Bernsteins out there on the internet who are trying to make money by giving shots to their patients, but that's not my recommendation. However, I'm not sure my doctor will give me a prescription for those shots. Doctors in Europe, the Netherlands, tend to be pretty restrictive. Would it be effective to still get my intake of vitamin D through supplements? I would recommend that you get your vitamin D from your vitamin B and your other vitamins from your diet. And if you're worried about whether your blood levels or tissue levels are adequate, you could get your levels tested. Your doctor can have your blood levels tested, and if you're not getting enough from your diet, you could expand the vegetables you're eating or the protein foods you're eating accordingly. And if you still can't get enough, then you might want to take a supplement. What are your experiences on how to stop candida overgrowth? Well, it's interesting that when I've been interviewed and I'm asked, what are the signs of type 2 diabetes? I say that for women, one of the earliest signs is vaginal candidiasis, that is candida infections. High blood sugars predispose potently for candida infections, and they can be prevented by keeping blood sugars normal. They can't be totally prevented. Once a person has a history of frequent candida infections, they might not be prevented totally, but they will not be anywhere near as frequent if you normalize your blood sugars. So there's normal blood sugars, and you certainly can see your gynecologist for medications to use to treat a candidiasis. There are a host of them. There are local or topical medications. There are oral medications, and so on. But the most important thing is normal blood sugars. Do infrared lasers really work to cure neuropathy in the feet? What really helps with alleviating the constant numbness and pain? I have no experience with infrared lasers. I would doubt that they would cure neuropathy. They would have to stimulate the regrowth of nerves that have been damaged or destroyed. And we know that if we normalize blood sugars, the nerves do regrow. So at least the peripheral nerves in the feet, in what I've seen in my patients. I've had many patients who came in with either numb or painful feet, and we reversed it. But as I've warned in my teleseminars, when you normalize blood sugars and if you have numb feet, as the nerves regrow or sprout, you can have severe pain for a few months while they're recovering their sensory abilities. Eventually, you'll have normal conduction and normal feeling, but for a number of months, while they're sprouting, you could have severe pain. But normal blood sugars, in my experience, always work. Does metformin damage a fatty liver? Not to my knowledge. Very unlikely. Can it cause fatty liver? No. Fatty liver in diabetics is caused by high blood sugars. I had a fatty liver for many years, starting a couple of years after I developed diabetes, throughout my teens, and into my 30s, until I normalized my blood sugars. And then after I normalized my blood sugars, the fatty liver took several years to disappear. And my fatty liver was way down below my rib cage, and when I touched it, it hurt. I've seen fatty liver on many new patients, and if they come back several years later with normal blood sugars, the fatty liver regresses. I have purchased your book, Diabetes Solution, which have just started. My question is, are your recommendations suitable for me if I am taking porcine, that's pork, insulins, as they do not act as quick as the modern day insulins? I didn't realize that porcine insulins were still being used. I was using porcine insulins when I wrote my first book. So certainly the current book can also be used with the porcine insulins. And I wish you lots of luck. How would you recommend female patients handle high blood sugars that often occur the week before their period? My period is also irregular and it's hard to track the swings that happen. Well, I see this very frequently in my female patients, and I only have two approaches, and one or the other usually works. The first thing I try is Metformin XR, the extended release Metformin. And we give them the full dose, which is about 2,500 milligrams per day. We split it up morning and evening. And that works for many, but not all of them. For the remainder, we send them to a reproductive gynecologist to get birth control pills to stop the periods. And when the periods stop, the wild swings of blood sugars almost always stop. Now, we usually stop the birth control pills for 1 month a year so that they can have bleeding to slough off any excess buildup of endometrium in the uterus. So for 11 months of the year, they're on birth control pills. This is from a person who was doing some physical activity, injured his shoulder, and although the doctor told him it would take a few months to heal, it's been 2 years, his shoulder hasn't healed. He wants to know if it's due to his diabetes. Well, there's a remote possibility that high blood sugars might slow healing of a shoulder injury. But probably the wise thing to do would be to see either a rehab physician who specializes in shoulders, that's a rehabilitation medicine physician, or a sports medicine physician who specializes in shoulders. I am 25 years old. I love to play soccer, and since I started low carb 3 months ago, I haven't been able to play soccer because every time I tried, my blood sugar would spike high to 8 to 9 millimoles, which is about 160 milligrams per deciliter. I started trying to take 1 unit of Apidra before, but that would cause me to crash after playing. I did read the exercise section in your book, but didn't find anything about what to do about it as a type 1. I hope you can help me figure out how to solve this problem. Well, I've solved this for a lot of kids whom I treat. Many of the kids find that their blood sugars increase after certain exercises, especially if the exercises involved competitive sports with another team. When they're practicing on their home grounds, the blood sugars don't go up, but then if they have a game with another team, blood sugars go up from anxiety. So we give them propranolol, which is a beta blocker, which curtails the effects of epinephrine, adrenaline. And it's the adrenaline that raises blood sugar. And some people find that when they exercise, the adrenaline raises their blood sugar. And then the exercise itself keeps lowering the blood sugar after they stop. So I would certainly ask my doctor to prescribe propranolol. We usually give it about an hour before the exercise. For kids, I give 5 milligrams. For adults, I give 10 milligrams. If this was a very large adult, and if the 10 milligrams didn't work, I tried 20 milligrams. I've never taken any long-acting insulin as a basal insulin during the day, as my doctor never recommended anything like that, something that alarms me after having read your book. I read that you prefer Levemir, but I'm wondering what you think of the new Toujeo and Tresiba insulins. Well, Toujeo is another name for Lantus insulin. And I will not use Lantus for myself when the only long-acting insulin available was the only long-acting insulins were Levemir and Lantus. I picked the Levemir because of the history of increased cancer in users of Lantus. This was demonstrated, I think, in 3 out of 5 European countries. 2 countries did not have this statistical significant large increase in cancer incidence. So there's a question mark. But the big problem is that the Lantus insulin has 165 times the affinity for IGF-1 receptors, that's growth hormone receptors, that human insulin has. And cancer cells are loaded with growth hormone receptors, and if you have such an affinity for those receptors, you're going to stimulate them, and I'm staying away from Lantus, which is Toujeo. I use Tresiba because it's a longer-acting insulin than the Levemir. If ketoacidosis causes osteoporosis, why isn't that the case with ketones? Well, I doubt that ketoacidosis causes osteoporosis, because osteoporosis takes many years to develop. It takes, let's say, 2/3 of a lifetime. And if you had ketoacidosis for more than a couple of days, you'd be dead. Ketoacidosis is a very severe dehydrating disorder that can actually dehydrate the brain. And if you had ketoacidosis for more than a few days, you wouldn't have it long enough to develop osteoporosis, certainly not 2/3 of a lifetime. And this person says, should I just ignore my home keto test meter? Well, you should be, if you're a diabetic, you should be looking at blood sugars, not at ketones. Ketoacidosis occurs with high blood sugars, and the ketones are incidental to the high blood sugars. So the game plan is to keep your blood sugars near normal. My blood sugars are always near normal, and ever since I've been measuring my blood sugars, which is since 1969, I haven't tested my urine for ketones. And why people are doing this, it's because industry is trying to make money selling ketone meters and so on. And there are also, I guess, some make-believe physicians who are keep measuring ketones in the urine all the time, as if that's a blessing. I found out that I have some plaque on my veins and arteries. Well, veins don't get plaque. And I wonder how you found out that you have plaque on your veins and arteries. The only way I know of is to find out about arteries is to get a coronary artery calcium score. I have drastically changed my diet and diabetic control. I am following almost 100% of your recommendations. Can you decrease the plaque buildup on your arteries? I am terribly frightened. I've been type 1 for 30 years. Well, this person is a survivor because when I was diagnosed, I was told that I would not live 30 years with diabetes. If you're interested in the plaque buildup, you could get a coronary artery calcium score, but let's say that it's high. Well, first of all, if you have high blood sugars, it's probably going to get worse, and probably the likelihood of the plaque breaking off may increase. If you have a high calcium score, there may be value in taking a statin because statins can stabilize the plaque. Not lower the calcium score, but stabilize the plaque so it doesn't break off. It's the breaking off of the plaque that's the hazard. There are some cardiovascular exercises that I recommend for people who do not have a high calcium score. Whether that's of value, when you have a high calcium score, you'd have to consult a cardiologist. One other thing that can be done, because inflammation can loosen the plaque, it's wise to do whatever you can to reduce inflammation. There are many inflammatory markers that I've discussed in my videos, so you could look them up on my videos, and there are treatments for some of these inflammatory markers. Can you tell us about ketones? That is the acceptable range. Ketones are usually neutral in their significance. That is, you really don't have to know what ketone levels are in your blood. If you're sick and dehydrated and vomiting and have a high blood sugar, it may be the ADA recommends you check your urine or blood for ketones, but the only thing you could do about it is lower your blood sugar and hydrate, and you should be doing that anyway if you have high blood sugars and if you're dehydrated. And if you're not eating, if you're vomiting, you're not eating, you're going to have high ketones just from not eating, starvation ketosis. If you're losing weight, burning fat, you're going to have ketones in your urine, and that's a good indicator that you're burning fat. So in a sense, it's neutral. It's not really going to tell you what to do. If I would think of one situation, if you're obese, trying to lose weight, Well, again, you don't even have to look in the urine for ketones. You look at the scale. You don't have to test your urine for ketones to see if you're losing weight. You could weigh yourself on a scale. So the whole business of ketones is a big question mark. Next question asks how to cover dietary protein with regular insulin. It's in my book. It's in great detail, and this person read my book and can't understand what it says. I first of all tell people that the formula in my book is an initial guesstimate that you try out once, and if it works, great, and if it doesn't work, you're going to have to modify it. And I use this with a new patient. Let's say the patient is having 6 ounces of protein for lunch. That might be 2 hamburgers. Well, I would cover the 2 hamburgers with a half unit of regular insulin per ounce. So 6 ounces would get 3 units of regular. So my initial experiment would be 3 units of regular to cover the 2 hamburgers. And if his blood sugar goes down after that lunch, I'd have to reduce the dose the next time. And if it goes up after that lunch, I'd have to increase it. That's how simple it is. Now, this person is asking about how many ounces are there in a packaged product. What if the packaged product does not show the weight of the product in ounces, but shows only the grams of protein? Well, if it shows grams of protein, there are 6 grams of protein in an ounce. Well, an ounce of hamburger weighs 28.5 grams. How could there be only 6 grams? Well, that 28.5 is fat and water, mostly. And only 6 of the 28.5 is protein. So if the package says 6 grams of protein, that's 1 ounce. If it says 12 grams of protein, that's 2 ounces, and so on. How do you avoid ketoacidosis with a low-carb diet? I have had type 1 for 50 years now, diagnosed at age 4. Well, I would recommend that this person read my book, Diabetes Solution. I would also recommend that he ask his doctor to prescribe injectable Tygan for use to stop vomiting, because the most common cause of ketoacidosis is vomiting, which causes dehydration and also causes high blood sugars. So you could stop vomiting within a few minutes if you inject Tygan. So ask your doctor to prescribe injectable Tygan, tell you how to use it, and that way you could prevent the vomiting that usually causes ketoacidosis. How do you get your blood sugars normalized if you're battling gastroparesis? You read my book, Diabetes Solution. There's a whole chapter on it. And what we do is we modify the diet. Sometimes for severe gastroparesis, we need a liquid diet. We may need to prescribe domperidone, also called Motilium, which we have to get from Canada. We may have to take some digestive enzymes with our meal. There's some possibility that R-alpha lipoic acid in a product called Insulo may help reverse the gastroparesis, but the evidence is uncertain. So all this is covered in the book Diabetes Solution. How would you advise to structure a diet for a type 1 diabetic who is looking to increase muscle mass for bodybuilding? Also, keeping a calorie surplus. Well, the guidelines that I use go like this. A sedentary adult needs about 0.8 of a gram of protein per kilogram of body weight to survive. And remember, an ounce of protein only contains about 0.6 of a gram. I'm sorry. Yeah. Wait a minute. Yeah. Only contains 6 grams of protein. So, just to survive, you need 0.8 of a gram per kilogram of body weight. If you're an average person going to work, walking up and down stairs in your house, maybe walking a few blocks during the day, you may need from 1 gram per kilogram to 1.2 grams per kilogram. If you're a professional athlete, you may need 20 grams of protein per kilogram or even more. So with those thoughts in mind, I ask the new patient how much exercise he or she gets, and I make an initial guess at the amount of protein using the range that I just stated, 0.8 grams per kilogram up to 22 or 30 grams per kilogram. And my initial guess will be right if the patient feels comfortable after eating the meal. Doesn't feel stuffed, doesn't feel too hungry halfway to the next meal. And that's how I play the game. We, by trial and error, adjust the insulin for the meal. I was recently diagnosed with type 1 diabetes at age 37. I have food allergies to egg, soy, and dairy, and have an extreme aversion to meat since being pregnant 6 years ago. I really want to make your plan work for me and keep my blood sugars as level as possible to avoid the long-term effects. Any suggestions? Yeah, there's fish, seafood, poultry, whey protein. All this is in the book. So you should read my book. There are all these protein foods, and there are low-carb vegetables. Shouldn't be a problem. Any tips for a newly diagnosed type 1 child age 10? Again, the book. However, if there's a child with diabetes in the family, this should be a family disease. The entire family should be following a low-carb diet and not make the kid feel strange. And one big problem that occurs with many parents, especially mothers, is that they don't want the kid to appear different to his friends, so they don't want him to eat differently from his friends. And what I say under my breath is, yeah, you'd rather have him die young. The friends, in my experience with kids, are always very anxious to help a diabetic person. They want to know what his blood sugars are. They will catch him if he's eating something he shouldn't be eating. They'll tell him he's acting funny if they think his blood sugar is low. And they can be very, very helpful. And they take pride and pleasure at doing this. So trying to keep things a secret is just the opposite of what's appropriate. Well, that's it for our September teleseminar. Please join me on Wednesday, October 30th for our October teleseminar. Thanks for listening and watching.